Welcome to this touch-in conversation activity. My name is Dr Sietze Reitsma. I'm an ENT specialist at the Amsterdam University Medical Centers in the Netherlands. And today I am joined by Professor Valerie Lund, and she is a professor of rhinology at the Ear Institute at University College in London, UK. And today she and I will be talking about minimizing the clinical burden of chronic rhinosinusitis with nasal polyposis. So this first section we will be talking about how can early diagnosis reduce the burden of chronic rhinosinusitis with nasal polyposis. As you might be aware, CRS with nasal polyps is a quite prevalent disease. If we look at people worldwide, around 2 to 4% are affected. Of course, in certain subgroup of patients, polyps are more prevalent, for example, in those with asthma. The disease has a number of characterizing symptoms, such as reduction of smell, nasal obstruction, and rhinorrhea or postnasal drip, but it also can present itself with facial pain or pressure, and even lead to hearing impairment or bad breath. And people suffering from this disease quite often have high disease burden. For example, they have a poor sleep quality, which results in fatigue during the day and has profound effects on their cognitive functioning and also their day-to-day activities. And there are also indications that patients are more often suffering from depression than you would expect them to do in a general population. So that would bring us to the first question. Professor Lund, Valerie, if I may say. ENT clinics benefit from the use of endoscopy to aid the diagnosis of CRS with nasal polyps. And based on the latest guidelines, how would you advise colleagues in primary care, allergy and respiratory settings to assess patients for CRS with nasal polyps? And when would you suggest referring patients to the ENT specialists?
Well, Sietze, thank you for asking that question. And it's, I think, really the most crucial thing is a careful history, as so often is the case. And we know that the cardinal symptoms, as you've already shown, for chronic rhinosinusitis is nasal blockage, discharge, loss of smell and facial pain, and those symptoms have to have continued for over 3 months. Obviously, if the patient is not suffering from sneezing or watery rhinorrhea or indeed itching of the eyes and nose, then that makes it less likely that allergy is playing a part. So if we then want to distinguish between the different types of CRS, we know that patients who have polyps, for example, will have a more predominant loss of smell and less facial pain, whereas facial pain tends to be more a feature of patients without nasal polyps. Similarly, we see more comorbidities such as asthma and non-steroidal anti-inflammatory exacerbated respiratory disease, as it's now called, in those patients who have nasal polyps. Now, our colleagues in primary care and allergy, respiratory medicine don't perhaps have any endoscopes, but they certainly have got otoscopes in some cases, and that can often be quite helpful to look in the nose. I think the other area that really one needs to concentrate on is the concept of the united airway. Certainly, we know that the mechanism of pathophysiology is very similar for CRS with nasal polyps and asthma. And certainly our respiratory colleagues may see patients whose predominant problem is in the lower respiratory tract, but many of those patients will also have problems in the nose and sinuses. So they have to remember that, ask questions, and if the history is suggestive, then they should refer those patients to ENT colleagues. We know that treating these conditions have collateral improvements in the respective systems, such as the chest being treated well helps the nose and vice versa. And so if you don't think about it, obviously they won't diagnose it. So I think that's the most important thing. And that really brings it down to education, trying to educate our colleagues that this is a possibility.
So, but the main part actually is history taking, and what I understand from you, any colleague could do that, especially also focusing on the lower airways. So that's a really helpful suggestion. Thank you for that. But then that would bring me to my second question here. How important is the assessment of disease severity to optimize the management of patients with CRS with nasal polyps? And what clinical tools would you recommend for severity classification?
I think we understand now that defining the severity of the disease is really fundamental to getting optimum management of our patients. And certainly, as we know in EPOS 2020, we offered a number of ways in which that severity could be assessed. And these are all validated methods. Starting very simply with a visual analog score, for example, for the cardinal symptoms and as an overall assessment using a scale of 0 to 10 centimetres. Patients can mark where they lie on that scale, and that will give us a score which has now been validated into mild, moderate and severe. So if you get a score of 0 to 3, then you've got no problems or mild symptoms. If it's greater than 3 to 7, moderate, and then greater than 7 to 10 is severe. Now, we also concentrate more and more on the effects of disease on quality of life, and there are quite a few general and specific questionnaires out there assessing that. The one that tends to be used the most is the SNOT 22. That has a range of 0 to 110, and we know that if patients score greater than 35 or 40, then they're likely to have severe impact on their quality of life. In fact, the visual analog score of greater than 5 in any of the symptoms has an impact on quality of life, and we know that the visual analog score correlates quite well with the SNOT 22. Obviously, we can look in the nose and we can use sort of objective quantitative measures looking at scoring of the polyps. Now, there are lots of different scoring systems out there. The one that seems to be most popular at the present time is a score of 0 to 8. That's 0 to 4 for each side of the nose. And again, if patients get an overall score of 4 or greater, we'd regard that as severe. And then finally, there are a range of tests, investigations, such as smell tests, for example, the UPSIT test or University of Pennsylvania Smell Identification Test. It's a scratch and sniff test. It's got a score of 0 to 40. It's again been stratified into normal smell, poorer smell and no smell, anosmia. And we know that if patients score less than 19, they're likely to have no sense of smell. So these things are all very helpful to put together a profile of a severe patient. And then, of course, there are a whole load of other things that the chest physicians use for asthma questionnaires, such as the AQ, LQ, etc. So we can put together those things. And in fact, in EPOS, we use the term SCUAD. It's not very, it doesn't slip off the tongue, but it basically says severe chronic upper airway disease. And it's there to really imply patients who have severe uncontrolled disease despite appropriate medical and surgical treatment. And I think it's an important term to use.
Well, thank you very much. So, and my last question for this part is then, what are the key challenges associated with diagnosing chronic rhinosinusitis with nasal polyps in the clinic? And what measures can be taken to facilitate earlier diagnosis and optimal disease management?
Well, I think the biggest hurdle actually is getting the patients. Once they get to us, we can take good history, examine them and possibly do CT scans and things, but getting the patients is really difficult sometimes. I mean, I have to say, working in the NHS, from the general practitioner's point of view, CRS doesn't really get a high priority. I mean, I could be cynical and say, well, nobody dies, so why bother to refer them? But I mean, basically, if you've got a national health system, there are financial considerations, and, particularly after COVID, they're not top of the list, despite the fact that we know these patients have quality of life effects, which are as great as patients with insulin-dependent diabetes and severe respiratory and cardiac disease. So it's a pity. And we also know that the longer patients wait from starting their disease to getting treatment, for example, surgery, the worse the outcomes are. And we want to get them their definitive treatment as early as possible before the chronicity translates into remodeling with potentially reversible changes such as fibrosis and new bone formation. So, I mean, it's really important that we try and get these patients as soon as as possible. I mean, certainly EPOS has got a number of algorithms, both for primary care and secondary care. And certainly in primary care, if patients have failed the sort of standard of care, which would normally be saline irrigation and an intranasal corticosteroids, after 6 to 12 weeks, you should seriously think about referring those patients, because that way you'll get them the best management. Once they get to us, of course, things go much better. I'm being unkind, really, but the fact is that we do have tools at our disposal to make the diagnosis and then to get patients the optimum management. And again, we have many algorithms that assist us with that.
So that would basically mean that we also have a task in educating our colleagues and maybe the populace or the patients themselves, that they shouldn't be happy with having many complaints, right?
Yeah, absolutely. I don't necessarily want to quote Tony Blair, our ex-Prime Minister, but he did say education, education, education. And you can't disagree with that.
No, I won't. So thank you very much, Valerie, for this enlightening answer. And that would conclude the first section of this talk.